Welcome to Nursing 150 presentation regarding Chapter 42 of your IGGY book. This is care of the patients with hematologic problems. And just to kind of an overview of hematologic problems, it's a problem that is resulting from an impaired production of one or more types of cells. And that's a big problem in the body. It can cause a large number of different problems because it typically involves some kind of interference with oxygenation and tissue perfusion, which we know is necessary for all of our organs and body systems to survive. They need the oxygen to support them. So that's what we're looking at. There's lots of different manifestations of a hematologic problem. We're going to talk about each one as we go through this presentation. So just a good definition of anemia. And this is anemia is an umbrella term that encompasses a lot of different types of anemias. So the definition, it's a reduction in either the number of red blood cells, the amount of hemoglobin, and or hematocrit. So let's talk about those three things. The red blood cells we know are the actual red blood cells that are produced in the bone marrow as stem cells, and they mature into red blood cells, and they have the oxygen carrying capacity on them. So let's talk about hemoglobin. Hemoglobin is the oxygen carrying capacity of the red blood cells. Normal adult hemoglobin is known as HbA. So we know that a low hemoglobin level would indicate to us that the patient has a low oxygenation level. So it might not mean that they have a low oxygen level, but the oxygen carrying capacity of the red blood cells is low, so it's not getting oxygen to the tissues of the body. So that's where we're concerned. Normal range, of course, it's a little bit different for males and females. Males is 14 to 18, females 12 to 16. So we need to know, to understand that if somebody has a low hemoglobin, we are going to see signs and symptoms of a low oxygen, which would be shortness of breath, fatigue, and low tolerance of any kind of activity. The hematocrit is referring to the percentage of red blood cells per deciliter of blood. So it's another indicator of how many red blood cells we have as opposed to the amount of plasma. So a low hematocrit count would be an indicator of a low red blood cell count. High hematocrit count would be relationship to a high red blood cell count. Normals for women, 37 to 47%. Males is 42 to 52%. And these do vary from book to book. I'm reading you the normals out of your IGGY book. So it's also important to understand that anemia is sort of a manifestation of some other disorder. It's kind of not ever really a disorder in itself. It's usually a result of some other kind of disorder. For instance, if there is an issue with the bone marrow producing red blood cells, and the end result is going to be anemia. These are general side effects of an anemia for whatever reason. Like we said, there's lots of different reasons for anemia, but these are pretty general assessments that you're going to see in a patient who has a low red blood cell count for whatever reason. Orthostatic hypotension, we know, is that when somebody changes position, when they go from a sitting to a standing position, they will drop their blood pressure, and that's due to the low blood count. Tachycardia is one of the first signs and symptoms of an anemia, and we're not talking about they get kind of tachycardic when they go for a walk. We're talking about just sitting there looking at you. At baseline, their heart rate is up. And that's because the body's trying to push what it has through to get the oxygenation to the tissues. So the heart's working a little bit harder. It's one of those compensatory mechanisms we have. The body's detecting that we have low oxygen getting to the tissue, so the heart tries to start pumping faster to get what we have out to the tissues. So that's a lot of times why we'll see a tachycardia at rest. The heart's trying to get the blood cells that we do have out to the tissues in order to get the oxygenation that it's craving. Murmurs and gallops, that's again because your heart's trying to work a little bit harder to get the blood out, and it could be caused by other disorders as well. And then, of course, your decreased pulse pressure, which just means that you're going to have, your pulses are going to be very faint. You could have like a thready pulse in a patient who's anemic, who normally has like a 2+ pulse in their peripheral pulses. So that's what that's referring to. So the first anemia we're going to talk about is something called hemolytic anemia. And basically what that's referring to is an autoimmune disorder when the body is incorrectly identifying the red blood cells as something foreign and they destroy it. So it's something that somebody may be born with. We understand now what autoimmune means. It means that our body is attacking itself. So it's basically as we produce the red blood cells, then the body's attacking it and killing it. So it's hard for that person with a hemolytic anemia to keep an accurate red blood cell count. There is a genetic link to a specialized type of hemolytic anemia. So it's typically something these people are born with. So typically in North America you will see the autoimmune type of hemolytic anemia. It is autoimmune, so basically they try to treat it by using an immunosuppression medication, such as a steroid. Sometimes a splenectomy can actually help with the immunosuppression. Sometimes they have to go to some chemotherapy drugs, which are kind of immunosuppressant as well. So it can be managed, but it is something that they will have lifelong to treat. Okay, this is a list of all the anemias that result from a decreased production of red blood cells. So the big thing to understand about these anemias is iron, vitamin B12, and folic acid are all required for the production of a normal red blood cells. These types of anemias are further broken down into two different types. One is the microcytic anemia, the other is a macrocytic anemia. And basically what this is referring to is a deficiency in a piece of the puzzle to producing a red blood cell will cause them to be smaller than normal, which causes them to be not as functional. And then the macrocytic type causes them to be bigger than normal, so it makes them abnormal and they cannot do what the red blood cells can't act like they should. Iron will cause it to be smaller than it normally should be. So basically these red blood cells that we produce without a sufficient amount of iron turn out to be pretty small and they can't act, they can't do their job like they're supposed to do. So basically when the body is deficient of iron, the red blood cells cannot be produced and mature like they should. They'll mature into very small ones. So we don't have the capability. We don't have red blood cells functioning like they should. The patient will have those signs and symptoms of anemia. They'll be weak, tired. They'll have an orthostatic hypotension. They'll have reduced exercise tolerance. They'll act like somebody who does not have enough red blood cells. That's the one thing about all these anemias. Essentially, all the signs and symptoms are the same. We just have to kind of put the puzzle together as to why they don't have the red blood cells that they should. One thing that I want to point out about the iron deficiency anemia, there's two reasons. First one is diet. So if we're not taking in enough iron in our diet, and that can happen sometimes if we have somebody who, sometimes vegan diets do not allow them to have enough iron. Sometimes women are usually, especially pregnant women, get iron deficient, and if there's a lot of bleeding with their menstrual cycle and things like that, they have a tendency to get iron deficient. The other reason that somebody might have an iron deficiency, I'm running out of room here, with the iron deficiency, the microtype, is the absorption of iron. abbreviate that. So basically they're taking in enough iron, but they're not absorbing it. For some reason, their GI tract is not absorbing it. So these people just would need another alternative form in order to get their iron levels up. So if just taking it in by mouth, it's not getting absorbed well, then they would need to maybe get shots of iron or infusions of iron. There is instructions on page 877, chart 42.4, about how to administer dextran, which is an iron injection. So you do have to use the Z-tract method for that type of injection. So just review that. Moving on to the macrocytic anemias, or the B12, the vitamin B12 anemia. That you can read about that on page 877. This is a macrocytic anemia. A deficiency in B12, again, B12 is required for us to formulate proper red blood cells. Without it, the red blood cells are made abnormally shaped and they come out bigger than they should, and they're not as efficient as they should be. Couple of different reasons for B12 deficiency. First of all, of course, if we are not taking in our diet enough vitamin B12, that typically, again, can occur in somebody who is a vegetarian or doesn't take dairy, and maybe they have a lactose intolerance. So that is also another reason. B12, there's two reasons. First of all is that diet, again, just they're not taking it in. And again, they could be somebody who does not absorb. So again, it's an absorption problem here. They have found that there is something called the intrinsic factor that we have in our belly that is what we require to absorb B12. If we are somebody who is missing our intrinsic factor, then it is called a pernicious anemia. So there's another term for you. So that person who has vitamin B12 anemia with an absorption problem, they have a more specific type of anemia, and it's called pernicious. Pernicious anemia are the patients that are missing the intrinsic factor. Treated the same way, except we couldn't give them more B12 in their diet because they're not going to absorb it because they don't have the intrinsic factor to absorb it. So they would need B12 injections. They need an alternate route for their B12 supplement. Folic acid deficiency is, again, the same thing. We require folic acid to be able to produce normal functioning red blood cells. When we have a deficiency in folic acid, which is typically from a diet, poor nutrition, then they could have an anemia because they don't have the ability to make normal red blood cells. It manifests very similar to a B12 deficiency. However, the nervous system function is normal, which can be abnormal in a vitamin B12 deficient person. So that's the difference between the two. A lot of times, folic acid deficiency appears in people who have like a belly problem and have a poor nutrition anyway. A lot of times alcoholics end up with a B12 or folic acid deficiency because of their poor diet typically. Treatment for this, again, is trying to improve their diet and getting them some form of a folic acid supplement, and that should take care of their signs and symptoms. Aplastic anemia is the final anemia that we'll discuss that is a result from a decreased production of red blood cells. Basically, this means that the bone marrow is not producing the cells. So this is when there's a problem in the bone marrow. About 50% of these cases are unknown. The causes of it are. Sometimes it happens with a reduction in other blood cells as well, like they might have a low red blood cell count, a low white blood cell count, and a low platelet count, or it could just be the low red blood cell count, which would be an aplastic anemia. So basically, what's going to happen with the patient if we determine they have the signs and symptoms of an anemia? They're tachycardic, their blood pressure is low, they have orthostatic hypotension, they have decreased or increased fatigue, they have increased trouble with any activity, they're short of breath all the time. First of all, we're going to do that complete blood count. We're going to see what their red blood count is. That would be low in any of these anemias. And then we'll look further. We'll look at their B12 level. We'll look at their iron level. We'll look at their folic acid level to determine if any of those are the cause of their anemia, of their low red blood cell count. If we rule those out, if their iron levels are normal, if their B12 levels normal, if their folic acid normals level, then we might then look to the bone marrow to see if the problem is coming from the production of the red blood cells in the bone marrow. So that's kind of how that we work through determining what the cause of an anemia is. Because, like, again, it's kind of a symptom of something, a disorder somewhere else. So it's a indicator to us that the patient has either some kind of a diet, nutrition problem, or they actually have a bone marrow problem. And that is when we would go to that bone marrow biopsy that we talked about in chapter 41, where we would have to aspirate out some bone marrow and determine if there are enough stem cells there for the body's actually making that. So moving on through chapter 42, the hematologic problems. This is the opposite of your anemias, the polycythemia. This means that you have too many red blood cells, and that can be a problem as well, because if you have too many, then your blood is very, very thick, and you're at risk for clotting, which can clot vessels, and it can decrease the circulation of blood and oxygen to other tissues. If it clots in a vessel somewhere or in an organ somewhere, then the blood flow is decreased. So it's something called hypercellularity, cell excess. So signs and symptoms of this is that your patient's going to be more flushed looking. They'll be kind of red in appearance. Polycythemia is actually pretty a serious diagnosis. It has to be identified and treated because it can be life-threatening. And if left untreated, their life expectancy is about 2 years after diagnosis. So it has to be managed well, a couple of different ways. There's actually a very good chart on page 879, 42.5. It talks about education for self-management of polycythemia, and that is increasing fluid intake. The purpose of that is to thin out the blood. The more fluid we put in, the less ratio. So we get more fluid per red blood cell, so it kind of thins things out and helps circulation. And you can look at all those. It talks about avoiding tight clothing, elevate your feet, keep that blood flowing. They might take anticoagulants, which would help to keep their blood from clotting and keep everything circulating. Soft bristled toothbrush. They're going to be at risk for bleeding because they have such a high blood cell count. So make sure you look over all that. Aspirin therapy has been used, and that is to keep them from getting blood clots. It's to keep their blood thin. So a lot of treatments are necessary in order to make sure that this patient does not get into a really dangerous situation. Can be thought to be an autoimmune reaction. Not really sure why this occurs, and there's no known cure for it. Something called pheresis can be done. It's sort of like a dialysis type deal. Actually, dialysis clinics will run pheresis. But basically what they'll do is they kind of take the blood out of the body like they do in dialysis, and they remove the cells. So they remove that excess red blood cells, and then they return the blood in the plasma to the patient. So it's kind of like cleaning out the red blood cells, all the excess. So like kind of like dialysis, when they do dialysis, they kind of take the blood out and they get rid of all the waste. And this one, they get rid of all the excess red blood cells. So that's something, but as you can imagine, that would be expensive. There would be lots of trips to the doctor, and it's you know, not something that's real easy to do. So. Okay, now we're going to switch gears a little bit and talk about the white blood cells, a disease of the white blood cells. Leukemia is the most prominent one. Essentially, that is an overriding of a bunch of immature white blood cells. So the bone marrow is producing the stem cells, which is the immature white blood cells, and that's also known as the blast cells. Those are immature cells in the bone marrow. And so basically what happens is they become overcrowded and they're non-functional. So you have a bunch of little baby white blood cells that can't do anything. So so it causes a lot of different problems. It's the immune system is decreased, of course, because now you don't have white blood cells that you need. And then it overcrowds so much that it can also make a person not have enough red blood cells or platelets because they're being overcrowded by these tiny little immature white blood cells that aren't doing anything. So it can cause a lot of problems for your patient. They are classified. The leukemias have different classifications. They can be acute, which would be a sudden onset, or chronic, and slowly onset, and some systems that persist for several years. They're classified by cell type. So you'll hear a lot of different terms for leukemia. Acute myelogenous leukemia is one of the most common form of adult onset leukemia. And basically, acute would mean that it was sudden onset. The myelogenous stands for it becomes from a certain type of cell. It's from the myeloid pathways. So it's basically what the name is what they kind of stem from for these different types of leukemias. So you can look over on page 881 in your Iggy book. It lists all the different classifications of leukemia. It's important to understand what type. A lot of them occur. The chronic phase, the chronic anemia or leukemias, typically occur in patients who are older than 50, and then your acute are kind of, anybody in their adult years, not necessarily over 50. So kind of look those over. The treatment is essentially about the same, and the diagnosis would be the same. So they would be diagnosed by that bone marrow aspiration, that bone marrow biopsy, where they take a look and see, they can find all the stem cells. Signs and symptoms of a leukemia, of course, would be that decreased immune system, somebody that's getting infections easily. They can also have signs and symptoms of platelet malfunction because, like I said, they could have a decreased level of platelets because of the overcrowding in the bone marrow. So they could start bleeding easily, bruise easily. Their gums are bleeding, rectal bleeding, blood in the urine, things like that might be an indicator of a leukemia. Other signs and symptoms is, tiredness, lethargy, loss of appetite, weight loss that's unexplained, increased tiredness, things like that would lead us to essentially first go to maybe do that complete blood count, see that we have, the CBCs, the red blood cells are low, the platelets are low, the leukocytes are low. So we would try to then go to get a bone marrow biopsy to determine the source. Physical signs, again, are those skin changes. You're going to have a pale person. They're going to have signs of anemia along with the decreased immune system and the signs of bleeding. So again, petechiae, remember that term. It says red raised spots that somebody might have on the surface of their skin, usually around their legs and feet. They could have some central nervous system changes, which would be headaches, seizures possibly if their blood counts get pretty low. They could have some joint tenderness. You can do diagnostic tests, and like I said, we would do that CBC, look for the red blood count, the white blood count, and the platelet count. You can also differentiate it into the blast phase. You can look at the blast so you can see how many immature cells are there. And if that's elevated, then we would know that that's probably looking towards a leukemia in a patient. You have a wonderful chart on page 883, chart 42.7. It's about risk for infection and the signs and symptoms that a patient could have a leukemia. It's a good rundown of the different body systems and what you might see. Treatment for leukemia could be some chemotherapy. Induction therapy would be the first phase, possibly. It's that intense combo chemotherapy, and you know, they're going to have all of those complications related to the chemotherapy, which is loss of hair. They get the sores in the mouth, because along with trying to kill these irregular stem cells that are overgrowing, we're going to also kind of kill some things that the patient has, as you know, as our natural things. And a lot of times that's hair follicles, and they get the sores in the mouth because we're kind of killing the protective barrier that we have in our mouth as well. A couple real important things to remember is teaching a patient with leukemia on how to protect themselves against infection. We want to make sure we keep their hospital room nice and clean. We don't want any fresh plants brought into their room, fresh flowers. They should really stay away from raw fruits and vegetables. Stay away from anybody, of course, that has been ill or been exposed to anybody that's ill. We really monitor their white counts. Remember, neutrophils are your first line of defense. They're the most numerous ones of the white blood cells that you have. And they sort of use that as a guidance into whether they should put someone in reverse isolation, which means that we protect them from us, because their white count is so low that they need to really decrease their exposure to people in general. And that's usually when their neutrophil count is very, very low, and it has to be like super, like almost non-existent for them to put them in reverse isolation. We typically talk about adults in this course, but adults could do this too. So they, you know, anybody that has a low platelet count or at risk for infection, they really should not be playing any kind of contact sports. You know, they're at risk for injury, they're at risk for infection, they're at risk for bleeding. So no contact sports for these people. Another treatment for a leukemia could be a bone marrow transplant. So basically what they do, when they determine that a person's bone marrow is not producing the normal cells that they should, that mature, they could actually transplant it with healthy bone marrow from another person, and they have to be a match. So educating both parties in this situation would be part of our job. You have to get a donor that's a match. They will basically remove some of the bone marrow from the donor. I highly advise you to read in page 885, read over obtaining the stem cells. It's at the bottom of the page. It starts at the bottom, and it talks about the 5 phases of transplantation, stem cell transplantation. The first part is where they obtain the stem cells. The best match for these people is typically an identical sibling, but a lot of times they can be successful with just somebody who is very closely matched to them. Once they find the suitable donor, they will begin the bone marrow harvesting, which will be step 2. They take it from multiple places. They take about 500 to 1,000 milliliters of marrow from the donor. It's then filtered, depending on where it's come from. If it's autologous, which is a self-donation, depends on how much they have to filter it. Basically, if it is a donor, then you have to kind of, after the aspiration, you monitor the donor for any complications. They're going to have a little bit of pain. Make sure they wake up from anesthesia, and they may need some fluids to keep them hydrated. I won't go through all the next steps, but a lot of this is just basically preparing the marrow to be transplanted. It's a good idea to look over that. On page 887 is kind of a timing of how it all occurs. The important thing to understand is that transplantation does occur. It's pretty simple, but it is an infusion. It's through a central line, like an ordinary blood transfusion. So I think people get confused sometimes. They think we transplant it back into their bone marrow, but it's actually almost like giving them a blood product. That's how it's transfused to them. But you can't use blood tubing because it could get caught in the filter with the blood tubing. But basically, it's very similar as to just giving them a blood transfusion. Post-operatively, we monitor them for any kind of infection or bleeding or any issues that could occur. So basically what we're hoping occurs here is that the transfused stem cells grow and that the person the person does not react to it, and the stem cells grow and work and function for the patient. This can be a difficult time for the patient to wait to determine how this is going to work for them. So the term failure to engraft is the term that they use when the donated stem cells do not grow in the bone marrow and function properly. So this would be a fear of the patient. You know, they have a lot riding on the fact that this is going to be successful for them. So basically, if the transplanted cells fail to engraft, the patient could die unless they try another transplant with stem cell that will be successful. So it's a very stressful time for your patients, so we need to support them and just, you know, help them to kind of keep their sanity while they're recovering from the transplant and trying to find out if it's going to work or not. There is another complication that could occur. It's called graft versus host disease. And this is usually when this is a donor that's not a relative. This can happen. So the cells that we actually give to the patient could actually have an immunologic attack on the host because it can acknowledge it as foreign because it's what it was made to do. So it could, as whatever's donated, the cells that are donated once it gets into the host, if those cells recognize the host cells as foreign, it could try to attack it. The areas that are typically damaged by this kind of attack is usually occurring in the skin, the intestinal tract, and the liver. There's a picture on page 889 that is manifestations of the graft versus host in the skin. They will just simply try to treat this with the immunosuppression medications such as methotrexate, corticosteroids, cyclosporin, those things. Any kind of immunosuppressant, they'll try to treat this disorder. Be sure to review care of a patient with these kinds of disorders as far as home care management. A lot of it's going to be protection against infection, support groups for kind of a very devastating diagnosis. The other thing that you need to make sure that they understand is the care of a central line catheter. They have a catheter a lot of times that they'll go home with. Sometimes it'll be a port that is surgically implanted in their chest. We'll talk about that a little bit more in class, but they'll need to make sure that they monitor it, and they might have to have home care people come out to keep an eye on it and flush it for them every so often. But it is a risk for infection to have that line, but they need that line. If they're getting chemotherapy, treatment, and so forth with that. So it's very, very important to make sure that those get taken care of so they don't end up with a whole other problem related to their condition. Okay, so moving on to malignant lymphomas. They are another hematologic problem because they are an overgrowth of the lymphocytes, which is a specialized leukocyte. This abnormal growth occurs within the matured lymphocyte, so it's not like leukemia. It kind of differs in that it's the mature lymphocytes are diseased and overgrowth. So it occurs in your lymph system that occurs throughout your body. If you think about, you've probably heard that you do have lymph nodes everywhere, and they're there to protect us. You have lymph nodes in your neck, under your arms, around your shoulder blade, kind of have some in the back of your skull. They're scattered throughout our body as a protective device. And basically, the lymphocytes, when they are overpopulated, it can cause tumors in these areas, in the lymph node tumors. These tumors typically are solid tumors. They have two major categories, lymphoma tumors do. It's Hodgkin's lymphoma or non-Hodgkin's. So, to compare them, Hodgkin's lymphoma is called such because it has a specific cancer cell type. It's called the Reed-Sternberg cell. It generally spreads from one group of lymph nodes to the next in an orderly fashion. So this is orderly. If you were to ask me if I wanted Hodgkin's or non-Hodgkin's, I want Hodgkin's. Hodgkin's is much more predictable. It is the most treatable type of cancer that we have. It's typically some external radiation of the involved lymph nodes is the single most common treatment for Hodgkin's lymphoma. Prognosis is good. It is called Hodgkin's because it has the Reed-Sternberg cell positive for that, so that's why they call it Hodgkin's. Not really sure what causes Hodgkin's. They think it's some viral infection that we might have had as we were younger. A couple of those viral infections include the Epstein-Barr virus, also known as mono. They think it could be remnants of that, possibly. Age group that gets Hodgkin's lymphoma is teen and young adults, and then it occurs again when you get to 50 or 60 years old. So it's those two age groups that it occurs most often. Non-Hodgkin's lymphoma does not have the Reed-Sternberg cell as a specific cancer cell type. That is how they differentiate them. This type of lymphoma is more common in men and in older adults. Of course, we don't know what the exact cause is. We do think it's some kind of autoimmune disorder. This typically manifests as painless. That's key there. They have swollen lymph nodes, but there's no pain to them. They're just kind of there and swollen, but they don't cause the patient pain. And it typically attacks the cervical, axillary, inguinal, and femoral nodes. Can be made after, the diagnosis is made after biopsy of that involved lymph node. Treatment is a little bit more complicated for non-Hodgkin's, and it's all according to what specific type of non-Hodgkin's they have identified, and it can be a combination chemotherapy in combination with radiation. All right, on to the last hematologic problem that we'll talk about for this presentation. Multiple myeloma. It's a white blood cell disorder. It's a cancer of the white blood cell that occurs with a plasma cell, which secretes antibodies. So it's part of the immune system that secretes the antibodies. There's an overgrowth of the B lymphocyte plasma cell in the bone marrow. So, in summary of all of these hematologic problems that we've talked about, it's typically an overgrowth of a certain type of cell, and you just kind of have to determine which cell that is in order to give it a name. So these lymphocytes, overgrowth of them starts to produce too many antibodies. So multiple myeloma is too many antibodies, essentially, produced by the lymphocytes. And this is called Gammopathy. Don't ask me if that's the correct way to pronounce it, but Gammopathy is what it appears to be. So it's basically an overproduction of antibodies that are called gamma globulins, and that's why they call it Gammopathy. Basically what happens, whenever there's an overgrowth of one of these, it typically affects the others because it kind of crowds them out. So again, you'll have fewer functioning red blood cells, white blood cells, and platelets because it's being overcrowded by this bunch of antibodies. This kind of cancer is typically of the older adult, older than 65 years old. It is higher in blacks than in whites in the United States, and much higher in men. Several of the treatments for this is going to be your chemotherapy. You have to give them something to try to suppress the overproduction of that lymphocyte that produces the antibodies. So it's basically a chemotherapy. It's going to be, according to what the oncologist feels that is appropriate for that patient. Just make sure you understand, again, you know how to take care of somebody with chemotherapy, so it's going to be the same treatment as for other cancers where patients are getting chemotherapy. And just also monitor them, because you know they're going to have those signs and symptoms of a decreased immune system, decreased red blood cells, and the chance for bleeding because it's going to affect their platelets as well. So all of these are kind of similar because they do affect your bleeding, your immune system, and then your oxygenation because of your anemia state. A lot of them do. So just try to keep that in mind when you're thinking about all of these different hematologic problems. Last but not least for this presentation is blood transfusion responsibilities. A lot of these patients that we've talked about will need a blood transfusion, so that is an infusion of packed cells or some kind of a blood product in order to replace what they do not have, what they've lost. So it's very important for the nurse. Only an RN with another RN at the bedside can transfuse blood. You have to make sure that you check multiple things. You have to, there's blood bank numbers, there's a system of checks that you have to go through, and it's typically to make sure it's the right blood, the right patient, the right match. Most patients that have been typed and crossed for a blood transfusion, they have a band on their arm that you have to check it with, and a lot of this is done within the electronic medical record. So 2 RNs at the bedside have to do this check. I've also posted a PowerPoint that's specifically about blood transfusion that you're going to want to review to make sure you understand the process for doing a blood transfusion. The other piece of this is staying at the bedside. After you start the infusion and the infusion reaches the patient's circulatory system, you have to stay at the bedside for 15 minutes. Most blood transfusion reactions occur within the first 15 minutes, so the RN has to stay at the bedside. After that, they can delegate the checks, which are vital signs checks, according to the policy of the facility that you're doing the blood transfusion in. You can delegate it, but then you also do have to follow up on any concerns or any change in the vital signs during the transfusion. This is just going over some of the monitoring for any kind of a blood transfusion reaction. Anytime we introduce something foreign to a patient, they do have the possibility of reacting to it. We've done a very good job in 2015 now of being able to type and cross a patient and match their blood so that they do not have any reactions. And you're going to have the patient also report any unusual signs and symptoms of itching, shortness of breath, all those things that may indicate allergic reaction. They want to make sure that they report to you. This concludes the presentation on Chapter 42. We will discuss things a little bit further in class, but make sure you have a basic understanding of this chapter, of the topics in this chapter.